Welcome to Leipzig.
Okay, great. All right, thank you. Thank you so much for having us. I also want to thank my partner, Dr. John Runback, for allowing us to participate. And we have here with us Dr. Mish Patel, working the contralateral side, Donna Freitag, our technologist, and Jana Reichlen, our procedure nurse. So this case is a patient with a severe chronic venous disease, 71-year-old male, bilateral complex 6 chronic venous disease. Next slide, you can see the picture of his legs, severe erythema, pigmentation, and ulceration as well. Next slide. So in the process, he came to us initially with an abnormal arterial Doppler study. We worked that up with the CT angiogram and did not seem to have any critical inflow stenoses, no combined arterial venous insufficiency, but we did note severe venous insufficiency. Next slide. Both in the peripheral venous system, specifically the greater saphenous vein. And he underwent EVLT as well as ultrasound-guided sclerotherapy treatment in June of 2014. Subsequently, he was doing well, and then the wound started to come back, and we put him in Unibut compression therapy and multiple sharp debridement therapies, and was doing well. And that was just recently in December 2014. And now the plan is, after reviewing the case again, we noted that he really has severe axial venous reflux. And we've sort of got very interested in the pelvic pressures and stenting potential outflow stenoses to help with the reflux and to be able to treat these patients easily. So the plan is really for bilateral common femoral vein access. We're going to perform pelvic venography, intravascular ultrasound. We'll obtain pressure measurements and possible stenting as needed. So we're going to go ahead and to the live images that we have here. Right now we have bilateral 11 French sheaths in each common femoral vein. Actually, from the left side, we have a 035 Advantage glide wire up and over, which can sometimes be helpful identifying the venous confluence. And we're going to go ahead and perform bilateral pelvic venograms from both sheaths, and we're going to see what we have. Okay, hold your breath, don't move. Can you arm the injector? Okay. Okay, so we'll run through these images here.
Just notably, I'm sort of standing in the back here. We talked about the presence of collateral, so I have a harbinger of events here, so I think we're going to find some disease. But again, we can't see those collaterals necessarily, which is interesting. I wonder if that's
Case, what do you think about that left side there?
Well, it looks perfect to me.
A little bit of reflux into the internal, but you're not seeing any collaterals?
No collaterals seen on that. We'll agree with that. So now we're going to go ahead and with the up and over access, I'm going to put the IVUS catheter in, and we're going to do a pullback. Usually we'll go from the IVC and down, but because we have the wire up and over and we're looking at both sides, I'm going to go from the right common femoral vein through the right external, internal iliac vein, and back to the left side and see what we find, if anything.
So Peter, severe axial reflux, lower extremities, what will trigger investigation of the pelvis for you?
Typically, if a patient has severe bilateral swelling and has at least some major segments of the lower extremity veins that are competent, that would concern me. If we have...
Is the patient awake?
Yes, he's awake. Again, conscious sedation. Are you seeing that, IVUS?
Yeah, if you could ask during the IVUS if the patient can put in a Valsalva maneuver, because that will dilate your veins nicely, and then you don't overestimate your disease.
All right, so when you go back to that...
Sure, let's go back and try that.